So we want to make sure that you know we are recording, and to please not include any confidential patient health information during the talk and during our discussion. Oh, and going back to that last slide, if you do want to receive a CME or CEU certificate, you will need to announce your name either over audio or through the chat box. Audio is preferred. We'd love to have a vibrant discussion today. And our disclosure and accreditation statements are on screen. Those are required to give out CMEs. And at this point, let's go ahead and take roll. And so who do we have out there on audio? And if you're having any trouble with audio, you can go ahead and chat to us, and I'll pop that chat box up for you. Just reading the little chat that I just sent out. If you need to pull that box up, it should be flashing for you either in the chat menu or under more. You'll find chat under there. And Maribel Lima says hello.
Hello.
But just to me. So just so you know, in chat, you can choose to send something just to an individual or to all participants and panelists. Choose the everyone unless you're just having some technical issues. And if you are, then send it to Kevin Worling, and I can help you through chat to get through any issues. Alrighty, so while we're waiting, oh, Daniela from First Choice. Maribel, thank you, Maribel.
Good morning.
And I see Loretta Wolf and Brittany Martinez is coming on.
Oh, great.
One moment. We'll have you. All right. Okay, I think, so anyone who just got on, if you see an error message, by the way, I just noticed that. That's the first time I've seen that pop up about sharing your screen. You won't need to share your screen today, so don't worry about upgrading your Zoom right at the moment. If you do use Zoom in other ways for other projects, etc., then you will want to upgrade that at some point. Don't worry about it right now. We're the only ones who need to share the screen, so we're in good shape. All right, I think we can go ahead and get started, and we'll go around the room and introduce ourselves.
Okay. My name is Adrienne McConnell, and I'm a quality improvement specialist here in Envision, New Mexico, and I work specifically on the Kellogg grant that is funding this program on reducing breastfeeding disparities through quality improvement. And today is the first session of a three-part series on breastfeeding and motivational interviewing. And our speaker today, we're very excited to have her here, is Dr. Jeannie Dalen. Dr. Dalen is a research assistant professor in the UNM Department of Pediatrics, and she earned her PhD in clinical psychology in 2008. Her expertise is in health psychology and behavioral medicine research, and is informed by over 13 years experience working in both the research and clinical world with chronic illness populations. Thank you for joining us today.
Thank you, Adrienne. Glad to be here. Kevin, can we get in the box? Perfect. Good morning, everyone. Thank you for joining us bright and early here at 8 a.m. in the Envision studios. I'm very happy to be here as always, and I like to think of myself as the informal Envision motivational interviewing expert. So I love to come in and have these talks with different types of providers on using motivational interviewing in the conversations that you have with patients around specific behavior change topics. And for particular, what we're going to be doing for this three-part series is kind of looking at motivational interviewing and having conversations around breastfeeding. So as Adrienne mentioned, this three-part series for you guys today is going to kick off this morning with really what I thought would be just a general overview or primer on motivational interviewing principles. And I always like to do my review in that I like to talk about the spirit of motivational interviewing, because if we talk about the spirit, I think many times within my trainings, we can kind of get caught up in learning kind of different types of techniques. And in trying to do techniques, I think we sometimes forget just the overall goal of MI. And so I'd love for you guys to walk out of here this morning with like, you know what? MI is something that is doable, it's approachable, and it's something that I think is a really good strategy or good fit for talking with breastfeeding issues with our new moms. So that's what the goal is today. And then I want to end today with some sources of breastfeeding behavior, some topics that have come out in a few research papers that give like a nice overview of certain topic areas that you can go more in depth in talking with your patients about whether or not breastfeeding is for them. So that's what for today's all about.
And Jeannie, I apologize. Can I interrupt for just a moment? It looks like Maribel is having trouble hearing. Although you did have audio before and now it's gone. And I'm just wondering if it's isolated to Maribel or if others are having the same issue.
Is anybody else having audio issues? Of course, if you are, you probably can't hear me.
You can't hear, but we did chat it out too. So we're getting a good feed from here. Isabel's doing well. Maribel, I'll chat with you privately to see if we can work this out. And sorry, Jeannie.
No, that's okay. All right, it'd be nice to be able to hear. Okay, so as we know, like with breastfeeding behavioral goals, there's two goals that are kind of simplistic ways to start thinking about it. Conversations that we're having with new moms can generally start just about initiating breastfeeding, right? Initiating breastfeeding once the new mom is at home with her baby. And then most importantly is discouraging early discontinuation of breastfeeding, i.e. earlier than either the World Health Organization recommendations or other recommendations through academic organizations that you use. And or what they're finding in the research is that many times, even before the mom's own goal for breastfeeding discontinuation, she will stop breastfeeding before that. So there's typically these three types of behavior that we're looking at, which is, like I said, starting breastfeeding and then discontinuation of breastfeeding earlier than recommendations or even earlier than the mom had planned. So it sounds simple, right? And so for us as trained providers, we have a lot of information at our fingertips about the benefits of breastfeeding for babies. And often, for the way we think of it as providers, what new mothers should be doing in terms of breastfeeding is very obvious to us as a provider, i.e. follow breastfeeding recommendations. We have a lot of information that shows the benefits, and we like to give that information to our patients. And typically we tend to think like, why would anyone not want to follow the recommended guidelines? However, what's not so obvious with our training and our knowledge is where new moms are on their journey towards breastfeeding and why they are sometimes reluctant to follow through. And that's what MI is all about. What we're going to be looking at is in terms of what you can think of as motivational interviewing, it's really incorporating the where and the why of behavior change or the behavior that we want to initiate. So if you can think of motivational interviewing is all about a relationship that you're going to have with that new mom. And it's really joining the new mother with compassion, joining her on her side and incorporating where she's at on the journey and why she's making the decisions she's making at the time in regards to breastfeeding behavior. So MI at its heart, just its definition is it's a collaborative conversation. That's all it really is. But it's made with one goal in mind, which is to strengthen the motivation for and commitment to change. So what do I mean about that? So the opposite of MI is a nice place to start, in that we tend as providers to focus on what a patient should be doing, right? So we are very quick to offer solutions and information. But it's really important to understand that information, i.e. guidelines or recommendations or what we feel is the appropriate breastfeeding behavior, that information is important and absolutely a part of the conversation, but information in and of itself does not equal motivation. And hopefully by the end of this conversation today, we'll have an understanding of why that's the case, especially when we tend to use fear-based information. And what I mean by that is anytime we try to say, you know, it's like your baby is going to grow 2 heads if you don't breastfeed correctly. Stuff like that, which I know is kind of, it's silly in its thinking, but sometimes we actually, we do this real fear-based type of talk with our patients to try to coerce them or persuade them or counsel them into doing what we think should be correct behavior. But what we have learned is there's actually a term called psychological reactance that happens in people, in that a person will actually argue more forcibly for the other side when someone else reinforces one side, i.e. it's almost like backing someone up in a corner where they feel like they have to kind of like we fight back. It's just an instinctual protective mechanism we have within us. So anytime actually when we try to advise, to just teach, to persuade, to counsel, to argue, to basically give our information, and that's it, we're actually putting that person in a position where they will actually fight against what we're trying to do. And so in the end, just information in and of itself actually sometimes does the opposite of what we're intending, which is trying to work with new moms on doing behaviors that are healthy for them and their new baby. I like my little boomerang here. So the whole little boomerang effect, again, it just can be a vicious cycle. So we have to think of then where does motivation come from? If it's not just about information and knowing what's good for us and our babies, where does it actually come from? So research done over the past 20 years has actually shown that motivation is actually not a static attribute. It fluctuates depending on time and place and what's going on in our life. Therefore, motivation can actually be modified, which is exciting because what they're finding is actually us as providers has a lot of control and a lot of influence in what our patients ultimately decide to do. Now, not through just information-based counseling, but actually they're showing that our style, our way of being with people in the room is actually one of the most important and ignored variables for predicting patient outcomes. And what they're finding is actually it accounts for more than variance than like patient characteristics. So us joining with compassion, us being a real person with that new mom in the room, being genuine, warm, having empathy, having respect can really go a long way in terms of having a rich conversation about how to make decisions regarding breastfeeding for their baby. So what that means is our task as a provider isn't just to provide information. It's not just to provide facts. Absolutely, that's a part of it. But if we can think about joining that new mom and thinking that our task instead is to help have that conversation with them, to actually elicit and enhance motivation to do what's good for themselves and their baby. So what we're going to do, and this is going to be the 3-part series, but overall it's like just recognizing behavior that's not in theirs or their child's best interest. Most importantly, though, is feeling confident to change. And this is another thing that we're going to be talking a lot about with MI. It's not just about having the information, the pieces, but we're going to be talking about how self-efficacy, having the confidence and feeling confident to be able to change is one of the main predictors in a person actually being able to initiate change. And then also, of course, developing a plan. So it's not just talking about all the benefits to breastfeeding, but really having a true conversation about what are barriers and facilitators to doing the actual behavior. And that's what we're going to end on today as well. So it's a conversation, you guys. MI at its heart is just talking with someone and meeting them where they're at in the room. And therefore, I think, with MI, the spirit of MI, we all can do this. Our conversational goal is we're hoping to promote sustained breastfeeding by increasing the mother's intent to breastfeed and then also increasing the mother's self-efficacy, being somewhat of a cheerleader. And that's really at the heart what we're trying to do. So I always say it's a conversation about change. Again, it is about relationship. If they feel connected to you, they are more likely to come back. They're more likely to have a real conversation and tell you the truth about what's going on. And therefore, you can really come up with a real plan for them to be able to do the behaviors that they want. It also has a particular purpose, though. This isn't just chatting with your new mom. It really has a particular purpose in that we're trying to just evoke and strengthen the woman's personal motivation for change. But it's collaborative versus confrontational. And this is where it can become very tricky for us as providers, because we truly are trying to work in the best interest of the mom and her baby. But we have to realize that we have to honor the person's experience and perspective rather than trying to impose or fight down a reality about breastfeeding that mom is not willing to see or admit to. And so in a sense, it's like we have to think more as like we got to go in there as their dancing coach rather than their kind of wrestling coach. Autonomy versus authority. And that's the biggest thing. Even when I think we try to feel like we're with them in the room, we tend to have an authority to us in that we can really stand behind our recommendations in a sense that makes them feel like we have all the answers and they really need to listen and follow us. That in and of itself creates a kind of a power differential where it's really difficult then for moms to actually talk about the struggles and how hard something as like breastfeeding can be. So we really want to affirm a person's right and capacity for their own self-direction. What we're trying to do is just facilitate an informed choice rather than telling people what to do. In the end, it does not matter how much information, how much that we try to do. Moms are going to make their own choices. And in a sense, it's nice because it takes pressure off of us as providers to recognize that our job is not to kind of wrestle our patients in the room. I think that's one of the things that actually leads to burnout because we try so hard to get people to do what we feel is the right, correct behavior for them, when really what we're there for is a sounding board. We're there to give ideas, to give the information we have, to help talk about the pros and cons. And so if it can really actually make our job a little bit more enjoyable too, and can make conversations and interactions with our patients more enjoyable as well. People make their own choices. So it's not just about educating and informing. It's about evocation, meaning the resources and motivation for change reside within the person. So that's the most important thing. We're not necessarily lacking key knowledge for change to occur. And that, I think, is the most important thing to think about. That many times, as you guys probably know in your own personal life, we know what we should be doing. Knowledge is not a scarcity in today's internet technology-rich world. The question is, what gets in our way, and what kind of can help facilitate really actually making behavior change that's good for us. So that's kind of the spirit. So I love to at least play one video that kind of gives an overall sense of MI. And what I'm going to be showing you now is just, it's about a 8-minute video, but it's a really nice version of MI in real life. And this one, I tried to find a breastfeeding one for us, you guys, but this one is actually about smoking cessation in New York City. So again, just, let's sit back and listen, and this kind of shows you a little bit of why MI can be so powerful. Do I need to? Oh, thanks,
Kevin. Okay, full disclosure, today's title is an overstatement, but only a little.
Those of us with a bad habit have probably heard all the guilt, pleading, and logic for change a million times. We're prepared to resist and combat every logical or emotional attack.
Especially smokers. More than most anti-addiction, they've seen the anti-smoking ads, the horrific images of cancerous lungs. Everybody's told them 100 times to just stop. And does it work?
Of course not. So let's look for BS you can use. All right, first let's find some smokers and a couple of Confederates. In the control condition, we'll have Cole and Josh try the traditional lecture approach.
Excuse me. Hey, you know smoking is bad for you.
Yeah, I know. Yeah.
Would you like to know where you can get some help? If you want to quit, then
Hardly any takers.
thank you.
90% of the smokers responded resentfully. Just under half even took the paper when it was forced into their hand. So, reminding people of something they already know but don't want to think about didn't work.
Now here comes the BS you can use. This time we'll have our intrepid Confederates try something different. We'll replace a tired lecture with an influential question. This time, Cole approaches the subject
Excuse me?
with a fake cigarette
How about a light?
and asks for a light.
How about a light? Why not? Why?
You don't breathe. You like to move, go fast.
This is fascinating. The adults are now telling the boy why he shouldn't smoke.
It gets even better. Now that the smoker's making the anti-smoking arguments, the kids turn it back to the smoker with an influential question.
So if you care about us, what about you?
Just look at the body language this time as compared to the control condition. You don't see defensiveness, you see openness.
Exactly. In this condition, close to 90% of subjects not only lectured the boys about the evils of smoking, but committed to trying to quit themselves. And it gets even better. One of them saw the boys later and came back to continue the rant.
Take it from me. Every time somebody bring it to you, or you see it, or you see somebody smoking, remember my word. It's not good. But I will quit, for sure, I have to. Otherwise I will die early.
Now, the skeptical scientist in me wants to ask, so was that motivation just temporary? Sure, they pocket the paper, but do they actually do anything?
Good question. When Ogilvy and Mather conducted the experiment in Bangkok, calls to the quit line actually went up 40% on the day of the experiment.
Wow.
We don't know if they actually quit, but we do know that their motivation lasted past the interaction.
Yeah, so let's talk about this. Why did that work?
I see a few things going on here, but let's focus on one of them. When you're trying to influence people who need motivation and not information, don't offer more information.
Your only hope is to avoid provoking what psychologists call reactance. The best way to do that is not with speeches, but with questions. Give them a safe environment to explore motivations they already have.
Exactly. The kids' approach allowed the smoker to feel emotionally safe, which allowed them to acknowledge their own ambivalence about their habit.
So I have to reintroduce them to values they already believe in by tricking them with a cute kid or a puppy.
Close. Stop forcing them to take the wrong side of the argument by lecturing them. Instead, use questions to help them explore their own motivations at their own pace. And it works too. Go ahead, try it at home.
I'm Joseph Grenny,
And I'm David Maxfield.
and that's all the BS for today. Sharpen your behavioral science skills by subscribing.
All right, you guys. So again, I recognize that video in and of itself was on smoking, but it just gives a really nice overview, and you can really see in action how powerful the difference is between lecturing someone and actually creating a safe space and asking just influential questions as well. And that's really just what we're trying to get to with MI. And I love how he says it. It's like, stop forcing your patient or your new mom to take what did he say? To take the wrong side of the argument. Again, that reactance, having to fight against you. We're really trying to be more collaborative. So how do we be more collaborative, right? So the biggest thing is thinking about kind of the stages of change model. And for any of you guys who have done any MI training before, absolutely have seen this from Prochaska and De Clemente. And really just what it talks about is that we tend to believe that motivation, you either have it or you don't, or that it's this linear change process, when instead, with many things in life, it's very much circular or a spiral, and that we go through many different stages of change in our thinking about whether or not to do something or not. And it'll be the same for breastfeeding behavior as well. What's interesting about this is the contemplation stage. So as you see, kind of moving in from not thinking to this like kind of light blue area and contemplation, that's actually a really rich area for us as providers. Because in the contemplation stage, this is where new moms are kind of starting to get all the facts. They're starting to figure out what they want to do. Maybe they've been breastfeeding for a few months and now they're trying to figure out, where am I really at with all of this? They are starting to acknowledge that they need to make a decision about what they're going to do, and they begin to think about various solutions. But they're far from making an actual commitment. And this is where you'll actually find in our patients where they feel the most ambivalence about taking action. And this is always this is a tricky spot, because typically as providers, when we see someone being ambivalent, we try to push for the side that really wants it, right? So we try to give them more information, more facts. But this is where we have to be really careful, because thinking about continuing breastfeeding or initiating breastfeeding is not the same thing as actually doing it. And so this is a really a rich stage in that this is where we start to have conversations about it, meeting people where they're at and not being afraid to talk about both sides of the equation. The best thing that we can do in our patients, instead of giving more facts, more knowledge, more lectures, is just to normalize ambivalence. Any behavior, and especially with new moms, can really feel like we're not sure what to do at any given time, right? We're all over the map. And the more that you can say, that is okay. It's amazing the power that happens in the room and the types of conversations you guys can have. So if you take anything from today's talk, if you are with a new mom who's not sure what she wants to do, just remind her that that is okay. That we get to reassure that the conflicting feelings, the uncertainties, the reservations, they're common. And it doesn't mean that she's a bad mom. Many new moms have experienced similar strong ambivalence at this stage. And even, I even put in a quote, like in actual words, it's like, you can say like, many new moms who reached this point and suddenly became worried, are able to turn around and continue to explore and discuss their concerns. And that's what we're trying to get at, is continual exploration and discussing of concerns, barriers, and facilitators. And then also the preparation. So what we're going to be doing, this again, like I said, today is more of an overview, just kind of getting us in the spirit of MI. And then next week, what we're going to do is we're going to actually be looking at specific techniques that you guys can use using MI principles. But it's always important that I think that the overall, just thinking about that contemplation stage and then the preparation stage, because if we ignore those two and we just want to jump into action, what will typically happen is you'll get a brief spoof of, kind of like of action, kind of like what we think of as like the gyms on New Year's Eve, kind of thing, where everyone's gung-ho and ready to go. And then it's followed by a rapid return to old behaviors. So we really want to set the stage at MI at the beginning. That's really where MI as the focus can be so powerful, is before anyone jumps into action. But like I said, of course, we'll be going over more specific techniques on how to do that next week. All right. So what I wanted to talk about now and really spend today about is just getting some feedback from you guys. And actually, let's see. Sorry, I just want to make sure. Yeah. Okay. All right. What I wanted to give you guys today was there's some great research that was being done in the University of South Wales in Sydney, Australia. So I pulled that up so we could start to have a little bit of conversation this next half hour on how other kind of agencies or hospitals are thinking about breastfeeding and MI. So what I'm going to share with you guys in a couple minutes is just a brief YouTube video that talks about their study. But one of the things that they shared in their paper that I thought would be really helpful for us to start thinking of is why breastfeeding could be particularly useful at MI, because there seems like there's a lot of sources that can either be a barrier or facilitator to a mom deciding if she wants to continue breastfeeding. And there was quite a bit. And I just thought, wow, what a rich and kind of complex situation that breastfeeding then becomes when you think of all the variables that are in play as a mom starts to make her decision. It's not just about what's good for my baby and what's not. The guidelines say this and yes. So I wanted right now to kind of go through all the various ones that they published in the paper. And I'm recognizing, I'm not sure if I have the site on this slide, so I'll be sure for next week that you guys have the reference for this paper. But just take a look at this for a while. This is going to be over the last 4. So sources of breastfeeding behavior, i.e. the barriers, what we'll see is either as a minus or a facilitator, is really first starting about the social norms. And that bottle feeding, the social norms around bottle feeding or breastfeeding, right? And it also includes the wider cultural social norms and beliefs and attitudes of the significant others, absolutely. The partner, the mom, the sisters. That bottle feeding or breastfeeding, right, is easier, convenient, healthier, more natural. So there, that in of itself is a huge conversation. Number 2, that mom actually feeling comfortable or uncomfortable about breastfeeding in front of others or in public places. As we know, there can still be quite a bit of stigma regarding breastfeeding, which is absolutely ridiculous, but there it is. Social support. Actually, social support showed to play a big role in moms' breastfeeding behavior, whether or not they were socially isolated versus feeling emotionally supported. We continue. Beliefs, their own beliefs about that bottle feeding versus breastfeeding is, i.e. easier, convenient, healthier, more natural. Beliefs and expectations about what is normal breastfeeding, i.e. the frequency of feeding or how milk let down feels, right? So then there's the whole planning, right? For whether bottle feeding or breastfeeding, buying the equipment, formula, the clothing, all of that. So there's many, many issues. And I think the reason why I like putting up these slides and us thinking about it is because this can give us food for thought about, how we could talk and have these conversations with our moms about all these various complex social issues. Then we get to actual intention, right? Where is the mom at? Where is her intention to breastfeed? And determination to overcome challenges encountered, right? Is she up to that task? Versus intention to bottle feed if there are difficulties, right? So if she encounters too many challenges with breastfeeding, you might find that her intention to bottle feed goes up. And so these are all, again, conversational points that can really give you a lot of information and direction about how to work with your new mom. Confidence and autonomy. And again, this is where we get back into that self-efficacy, us as cheerleader rather than informant. Feeling able, new mom feeling able to try out and find their own techniques for feeding rather than having to stick to textbook methods. And I think that's a really important thing. And one that we're going to talk about in MI is there's more than one way to skin a cat. Meaning that we really can all find a way that works for us, given our own strengths and weaknesses and environmental context. And I think the more we can be creative with new moms and let them know that they can figure this out in their own way can really up the confidence and autonomy that they're looking for. Big one too, positive or negative prior experience of breastfeeding and or breastfeeding support for those moms that are, this is not their first rodeo. Quality of information and advice. So again, information and advice has its place, right? It's not that as providers we should not be using the training that we have in and of itself. It's just in and of itself we need more than just giving the information. It can be, but the quality of the information that we give them, the quality of the advice, and how it's delivered more in a conversational context can really, really help kind of increase the motivation, and the confidence and autonomy for change. Is it consistent? Has it been inconsistent? Has it been accurate? Has it been inaccurate? Information from either social sites or other professional sources of supports. And it's always fun. I don't care what type of behavior you're looking at. When you ask a person what they think they know about the certain behavior, it is amazing what comes up in terms of what they think they know. And sometimes people are spot on, and others it's like you don't know what website they were on and where they got the information that they did. And so it's always good to have a real conversation about what they think they know and help fill in those gaps. And then an important one too is being able versus unable to access support services right at the time of birth, right? So having plans in place to prepare prior to birth and then soon after birth and then at crisis points. So planning becomes a big one as well. And then here we go again. I mean, look at all of this, like physical factors. Was it a difficult birth? What's the hospital environment? Positioning, pain, latching, milk supply, frequent feeding, return to work or other separation from babies, managing the siblings, and other demands on times and resources, lack of sleep, change in routine, skin-to-skin contact, the big latch. So as we see, again, the reason why, just to give us some ideas about, it's not just simple as, you know, recommendations say. I mean, when you look at this, there's so much to talk about and so many environmental and cultural and social influences that can really determine how a mom makes a decision about whether or not she's going to continue the behavior or not. So it's interesting to look at, and it gives us a lot to talk about. So I wanted to at least try to find you guys something that actually shows MI with breastfeeding. So what we're going to do is this is just a quick couple-minute video that just talks about, as I mentioned, a professor or doctor down in Sydney. And I love her accent, so that's why we're watching this one. And she's going to just give a quick overview, just very simple, about how they think about MI in the study that they did with breastfeeding moms. Oh, look at you, you even started it at 30.
Well, I did research into breastfeeding, and what I was looking at is how long do women continue to breastfeed. We know that they're recommended to continue at least to 12 months, and breastfeeding should be the only thing their baby has for the first 6 months, but that's not what happens in Australia. In fact, 40% of babies are not breastfed at all by 6 months. So what I did was I looked at breastfeeding outcomes at 4 and 6 months using a cluster randomised controlled trial design, and we found that we're able to significantly increase exclusive breastfeeding at 4 months thanks to an intervention provided by practice nurses. I think anybody can help with making this change in behaviour, but the key features we found, which was consistent with the literature, was that people needed to have training, they needed to know about breastfeeding, they needed to know how to effectively communicate with their patients, and we used a motivational interviewing model so that they were supporting patients to move towards a goal. And in fact, that was one of the reasons why the model was attractive to the practice nurses, because there was no way they wanted to beat mothers around the head. They were quite keen, however, to have something they could offer mothers wherever they were at. And we talked about the stages of change model, where the mothers offered them a red, yellow or green traffic light type signal when they talked about breastfeeding for longer. Well, what we devised was an A4-page laminated flowchart for the practice nurses, and that helped them to identify when they said to the mums, well, the recommendations are these, how do you feel about that? How would that work for you? They were able to identify whether the mother's response was, no, not going there, or, oh, not really sure if I can or I want to do that, or perhaps, yes, that's for me, straight ahead. So the practice nurses had a specific intervention that to then follow through with the mothers depending on how they responded to the question.
Wow, that's great. Thanks. So as she said from the literature, I love her accent. I know. She's like, we did not want to beat moms over the head. But I think this was just a really nice example of just a simple intervention where in using MI, they were able to have like a structured conversation delivered by practice nurses. And I thought, what a cool thing to actually share with you guys. So I actually took some pictures off of that YouTube video for us to kind of go a little bit in depth, because it gives us kind of food for thought on how we can work with MI. Again, of course, next week I'm going to be showing you guys some different techniques. But one of the things I thought was really cool was this conversational tool handout. And what it looked like they did is really just had, like what she said, red light, yellow light, green light. In terms of red light being pre-contemplation, right, from the stages of change model, the middle contemplation, and then support more of the planning, just like what we talked about. And I know it's kind of hard to see because I really just finagled this off a YouTube video, especially the red, so I'll read it for you. But really what she had is like, giving the recommendations, in the last week, has your baby been breastfed at all? Is your baby only having breast milk? And can you tell me how your breastfeeding is going? And then, so, I don't know if you've heard, but here's the recommendation. How would that work for you, right? Just putting it back in their lap. And then given whether mom said, nope, then they would say like, okay, that's kind of the red light. So it says, breastfeeding is a learned skill and there are challenges. And there are some facts you might want to consider before making your decision. But you'll decide what's best for you in the end and kind of leave it at that. Versus the middle ground, like unsure. Okay, so what do you like about breastfeeding? What do you not like? This is a contemplation stage where I said that really nice, rich area for us. And it's going to be that yellow or mustard color that we're going to be looking at in detail next week to really give you guys some more skills about what we can do at that middle ground, versus the green light, which is more of the preparation, considering the barriers and facilitators for those who really want to continue and are heading that way. So I just thought that was a really nice model that they used with, and I like the thinking of the red light, yellow light, green light. It was a nice way. All right, you guys. So again, today I know was like a really brief primer. It wasn't really meant to, make us MI experts, but just really bring the attention of MI to the topic of breastfeeding and conversations that we have with new moms, and just recognizing that when it comes to breastfeeding, it's not as simple a decision as one may think. There might be other things that get in the way. And that it's okay to have that conversation, that we can start with the guidelines and the recommendations, but really where the richness of the conversation happens is working with that mom and talking about, the things that are happening in her life and how we can really work with it. So the more that we can back up and just have true conversations to really be collaborative with our patients rather than confrontational, we can get much farther along in really talking with them. And so really the goal is kind of thinking through all those different conversational topics. And then for you guys in your practice, just to get a sense, with the few minutes that we have left, if this is something that feels like, this is what we need in our clinic, or this is something that I would like to work more with. And then, like I said, then we'll move into next week with actual real techniques to use with MI in that little yellow mustard area for contemplation phase. And then the third session in a couple weeks is going to be an opportunity for you guys to bring in some real life cases and questions, and we can kind of mull it over and think about some different MI, ways that we can use MI to help you with the patients that you currently have. So that's kind of where we're at right now. Any thoughts, comments? We're totally lost. We love this. Kind of just, your thoughts on where we're at. I do know it's 8:45 in the morning.
Just a comment, when you were going over all the different things that can be going on in a woman's life that are, creating a challenge or support around breastfeeding, just in talking to women, when I talk to people about what I do here at work, if they're breastfeeding, they share with me, stories of challenges. And one that I heard recently was that she really wanted to breastfeed, but her grandmother didn't want her to because it was seen as only something poor people did.
Interesting.
Yeah. And I was like, wow, that's a powerful message. And how do you work with that and around that,
Absolutely. Absolutely. And it's, it's honestly, sometimes I think it's having that conversation. Sometimes when just having the conversation, I'm a psychologist in private practice, and it's amazing how, we'll say, like, when we actually say these things out loud to another human being, like, we recognize, like, wow, look at what's really influencing my thinking. And sometimes it's for the best. And then sometimes we can be like, you know what, as much as I appreciate grandma's opinion, like, I recognize, like, I need to make another decision for myself. So I have learned to not underestimate the power of just putting it out on the table, But yeah, that's the thing. There's so many beliefs and social norms, I think, around this behavior that it's an interesting dynamic.
Yeah, it is.
Yeah, absolutely.
Yeah. All right. Don't have any.
Just a comment.
Okay.
This is awesome. Thank you for sharing this information. I'm looking forward to learning more for myself, coworkers, and patients.
Awesome. Great.
Thank you.
Yeah, you guys. And like I said, next week we're going to dive into some good techniques, but just recognizing that, it's not just about techniques. I think if we can just sit back and just have conversations with our patients, it's that you're 90% there, right? And so what we'll be doing next week is just more of like tweaking and kind of getting a little bit more proficient at some things that you can actually take in the room. So thanks, Maribel.
All right, and thanks everyone for joining us, and we hope you can join us in a couple weeks.
Actually, next week.
Is it next week? And then
2 weeks.
2 weeks, right?
2 weeks.
Yeah. And then and we also I emailed out forms for everyone. Just wanted to remind you, if you have any cases that you'd like Jeannie to discuss with you, everything is kept confidential. We don't record that session. So please go ahead and feel free to send those in, and we look forward to speaking with you in the future. Thanks for joining us today.
Thanks, everyone.
Thanks, everyone. Here's Jeannie's contact information. That's also on the slide set, which is now available on the website for download. If you haven't already chatted in your name or and where you're from, sorry, multitasking, then please do so at this point, just so you can get the credit and we can send you out your CME certificate, which we do the month following the session. So, and in one moment, we're going to go ahead and mute ourselves here, and thank you very much, everyone, and I'll leave the room open. I'm also going to chat out our survey for today. If you wouldn't mind taking just a couple of minutes to answer the survey. It's about technical issues that you might have had, and the topic, objectives, things like that. It helps us improve. So if you can hang on for just a moment, I'll have that out to you. So thanks again, and you have a great day.
Thanks, everyone. See you in a couple weeks.